Here we're moving on to venules and veins. This is a pretty short packet, and it really just gets into the distal branches of our vasculature, okay, and how they differ from some of the proximal branches. So some of the main differences that we see here in veins are that they have valves. So specifically our peripheral veins, our limb veins, they have valves to allow for that unidirectional flow. Remember, as we get more distal in the vasculature, the pressure starts dropping off, right? So the pressure in our veins is not as high as the pressure in our arteries and other proximal branches. And so we really need to rely on either gravity or valves or some of our skeletal muscles in order to help with the pressure, in order to move that blood along and aid with that venous return. Okay, so that's going to be some of the challenge that we see here in the veins. Another thing I want to point out with the veins, another major difference, is that they have a wider diameter, so they can accommodate more volume, right? We talked about this before, than a wider diameter than what we see in arteries. And this is really owed to the substantially smaller layer of smooth muscle here. Now, the smooth muscle layer is not absent. It's very much there. I'm going to talk about venomotor tone, which is an important regulatory property of veins that is brought about by this smooth muscle. So I don't want you to think that there's no smooth muscle in veins, but it's certainly not as thick as the smooth muscle layer that we see in arteries, okay? And so this gives us more space to accommodate volume, which is really the job of veins, accommodating most of our volume, as we'll see here in a bit. So let's start by looking at venules really briefly. They're not very important. They aren't, very different from capillaries to some extent. They're smaller than arterioles. They connect from capillaries to veins, and then they have a little bit of smooth muscle in their wall as well. There is still some exchange happening between the interstitial fluid and venules as well. So we can think about venules as being somewhat of an extension of capillaries in terms of still allowing for that exchange between interstitial fluid space and the capillary itself, okay, the plasma and the interstitial fluid. And so that is why they're much smaller. They still have a thinner wall, and then we'll see that the veins end up having somewhat of a thicker wall where that exchange is not actually taking place. So getting into veins here, larger in diameter, but thinner walls. They have the valves that we talked about specifically in peripheral veins. So limb veins, once again, your upper extremities, lower extremities, and not so much in central veins. So think about your inferior vena cava, your superior vena cava. Those veins have other mechanisms. Those veins have other mechanisms to help with that venous return, and they don't actually have valves. And really the purpose of valves is to help with unidirectional flow. So think about standing, right? The action caused by gravity would want to pull blood to the lower extremities. And so having veins in those structures, the limbs that kind of dangle, is really important with that unidirectional flow and preventing backlog or buildup of blood, which would otherwise occur. Okay. Now, veins are a volume reservoir. So comparing to what we spoke about in terms of arteries, arteries being a pressure reservoir, veins are much more compliant vessels. They have little elasticity to them, the way that arteries do. And so they're pretty obedient. They can accommodate lots of volume without pressure changes. Little pressure changes for large volume changes. We kind of made this connection earlier as well. And so in this way, they can act as a volume reservoir. In fact, most of our blood, 60% of our total blood volume at any given time is really sitting in our systemic veins. Okay, so they're really the volume reservoir for all of our blood volume. And so this graph here helps to really highlight that relationship, the relationship between arteries and veins. And on this, this graph in your notes, you can probably write in here why this is occurring. So this is comparing volume here on the Y to descending pressure on the X. And what that's showing is how much pressure is exerted on the wall of this vessel with volume changes. And so arteries exert a lot of pressure for even small changes in volume. This is because they're elastic and they're not compliant. We made that connection before, right? And so really practically here, if you stretch on the wall of an artery, there's a lot of pressure stored in that wall as it tries to collapse back because of that elastic nature, because of that non-compliant nature. Veins, on the other hand, they can distend, and stretch for quite a bit. They can accommodate a lot of volume without exerting much pressure in terms of the pressure exerted in that wall. So I can dump quite a bit of blood into a vein. It will just be, obedient and compliant. It will expand and accommodate that volume quite nicely without having pressure stored into the wall. In other words, it's not trying to snap back to its original shape the way that the artery is, okay? So volumes can accommodate large volume changes with little change in pressure. Arteries exhibit a lot of pressure for even the smallest change in volume. Okay, and this is because arteries are elastic and non-compliant. Veins are compliant and not really elastic. Okay, another way to express this, arteries are pressure reservoirs, whereas veins are volume reservoirs. Okay. On this pie chart here, we can see that most of our blood is actually sitting in our veins and venules. So at any given time at rest, we've got most of 60% of that blood sitting in our veins, and then 15% in our arteries and arterioles, so a much smaller percentage here. Some of it in our pulmonary vasculature, some in the heart, obviously, and then a little bit in the capillaries, right? But most of it is sitting in the venules and veins. And so this is really where the reason that we have veins being able to accommodate volume changes, because they are able to hold our blood volume. Arteries cannot hold our blood volume because they're going to exert more pressure if they accommodate larger volumes. Now we're going to get into some of the factors that influence venous return. So I talked about this earlier. The main challenge that we see in the veins is that they have to try to get blood back to the heart against things like gravity, against distance, right? Think about your limbs, upper limbs, lower limbs. And so that's the main challenge that we see in veins. And some of the factors that influence or help with that venous pressure or venous return is what we're going to get into here. So the first factor is the skeletal muscle pump. And in anatomy lab, I usually point this out, but a lot of our veins are really superficial and they're nicely embedded between, strategically between some of our skeletal muscles. So think about the heads of the gastrocnemius muscle, and we've got the popliteal vessels nicely nestled in between there. The vein is more superficial and the artery is deeper, right? And so the vein is in a position to be nestled between the heads of these skeletal muscles. And we see this in other areas in the body as well. And what this does is when the muscles contract, the veins can then squeeze, increase pressure, and help with that flow back to the heart. But then when that muscle relaxes, the valves are there in place in order to prevent that backflow that would otherwise happen when that muscle relaxes. And so the one-way directional property of the valves coupled with the skeletal muscle contraction and relaxation helps to overcome this challenge of gravity and help with that venous return. Okay, so this is kind of highlighting that, this example here. So basically when the skeletal muscle is contracted, so think about, standing on your tippy toes, the gastrocnemic muscles, the heads of those muscles contract, they squeeze down on the popliteal vessel, right? And so that's going to force more blood up towards the heart. And the valve in the distal part here that's not being pinched off is preventing any backflow from this region back down into the previous vessels. When the muscle relaxes, on the other hand, the valve in the distal area here, proximal, it's going closer to the heart. So this valve is now going to close. And so where we would have otherwise seen the blood that you just worked so hard to squeeze in this area, otherwise it would have just flowed right back down here. It cannot do so because that valve is now closed. So we have the contraction and relaxation of the skeletal muscles coupled with the strategic location of valves that are working in concert with one another, and that helps the blood to move in one direction, okay? So when the muscle contracts, the proximal valve opens, the distal valve closes. When the muscle relaxes, the proximal valve closes, preventing that backflow, and the distal valve opens, allowing more blood to come into this region so it can then be guided towards the heart, okay? Let's see, I'm gonna pause here, some questions coming up. Are all valves equally placed throughout the body? So they're sort of strategically placed. I don't know what you mean by equally placed, but they're pretty, you know, evenly distributed throughout strategic locations like our major veins. So you're not going to find them in distal, really distal areas like fingers and so on, but you will find them as you get to larger veins towards the hand and towards the arm and so on. And same thing in the lower extremities. Okay. And then really here, we want to understand that what's causing this opening and closing of the valves here is the muscles that are working in that region as well. Okay, so I really want to make that relationship clear. The second factor here, the respiratory pump. So this happens because of our respiration. And so if you take a nice big deep breath, so imagine everyone can sort of take a nice big deep breath and hold at the top of that inspiration. And what you should feel is your abdomen compress, but then your thoracic cavity expands. Okay, if you're holding at the top of that inspiration. And what's happening there is you have increased pressure in your abdominal cavity by sucking in your abdomen pretty much. And so the abdominal organs put pressure on the veins in the abdomen. At the same time, you have decreased pressure in your thoracic cavity because now you're opening up the thorax, you're bringing air into the lungs. And so as you're distending the thoracic cavity, you decrease the amount of pressure that's put on the proximal parts of those same veins. What that creates is a pressure gradient. So high pressure in the abdominal veins, low pressure in the thoracic veins, that creates this gradient where blood now wants to move according to that gradient from high pressure in the abdominal part of that vein to low pressure in the thoracic part of that vein. And so what that does is it increases your central venous pressure. In other words, the driving force that now wants to move blood towards the right side of the heart. And that is what increases that venous return. Okay, so that just creates a gradient where blood wants to favorably move towards the heart. And then the third factor here is regulating our blood volume altogether. This is more of a long-term regulation. And so what this really means here is we can regulate how much blood is in our body, essentially, and that will determine how much blood volume we have and how much venous pressure is being exerted. Okay, so if I have less blood volume, and when we talk about blood volume, we talk about what's happening in terms of regulation through the kidneys. So the kidneys have the ability to regulate our blood volume. We can lose more of that volume as urine. We can retain more of that volume to help aid in restoring or retaining blood volume and likewise blood pressure. And so if more blood volume exists in our physiology, it's going to exert more pressure in our veins. If we lose blood volume and we have decreased blood in our body, then we have decreased venous pressure in our veins, okay? And so more of in a long-term regulatory way, we can manipulate how much blood is in our physiology and therefore, how much pressure it's exerting in our veins. And then the final factor here is venomotor tone. And venomotor tone is the ability of that very small layer of smooth muscle that's in our veins to be influenced by the sympathetic nervous system and therefore contract. And so that is going to help with pushing that blood back towards the heart. So remember, all of these factors are really trying to help guide that blood back to the heart, okay, against gravity and some of the other factors we talked about. And so the venomotor tone is exhibited by the small layer of smooth muscle that lines the inside of our veins. And when that smooth muscle contracts under the influence of the sympathetic nervous system, okay, so we have norepinephrine acting at our alpha adrenergic receptors. Remember, alpha adrenergic receptors are active on our vessels, veins included. And so when sympathetic nervous system via norepinephrine binding to these adrenergic receptors causes smooth muscle contraction, that is what we call venomotor tone. What that does is it helps to push blood back to the heart. In other words, it decreases the venous compliance. It makes the veins a little bit less obedient and rebellious, if you will, and they start to give that pushback on the blood, which kind of guides it or shoves it back to the heart, okay, increasing that venous return. All right. So I'll give a slight pause here to see what questions we have about those 4 factors, and then we're actually going to look at all 4 of those factors in this flow chart here. So we talked about venomotor tone, that smooth muscle layer that helps to slightly decrease compliance, allow for more of the contraction of that vein and guiding blood back to the heart. We talked about the respiratory pump, the way that we can inspire and create a pressure gradient that moves blood back to the heart as well, more in our central veins. We talked about the skeletal muscle pump in concert with the valves that also helps to guide blood back to the heart. And then we talked about more of that long-term regulatory factor, where if we regulate blood volume, either decrease or increase blood volume at the level of the kidneys, we can also influence venous pressure as well, either up or down. Okay. So let's start going through this flow chart here as a way to kind of review all of this. So if we increase sympathetic nerves to the vein, or increase the activity of sympathetic nerves to the vein, again, think here, norepinephrine binding to those alpha adrenergic receptors, we allow that smooth muscle to constrict or contract. That increases venomotor tone and that decreases venous compliance. Remember, venous compliance is the obedience of our veins. And if you create a constriction or contraction in that vein with that smooth muscle, you slightly decrease that compliance, okay? The other three factors here, which also align with increased venous pressure, are the activity of the skeletal muscle pumps in the peripheral limbs, so the muscle pumps along with the valves, the activity of the respiratory pump really in the central veins, so the inferior vena cava, superior vena cava, and then the blood volume, which is more of a long-term regulation there. All of those factors help increase the amount of pressure. So venous pressure, which is the amount of pressure in our veins. So how much pressure is moving that blood back to the heart? That's going to increase venous return. How much blood is making its way back to the right side of the heart, okay? That's going to increase atrial pressure, right? Think about the heart now. So if more blood is coming back into my right atrium, my atria, that's going to increase my end diastolic pressure. In other words, my preload, how much blood is filled into that atria. That will likewise, increase my end diastolic volume, okay? And then that will also increase my stroke volume and my cardiac output. So the connection here, the big picture here, and you can kind of make this in your notes, is that if the heart can fill adequately, the heart can pump adequately, okay? If more blood is coming back to the right side of the heart, more blood can leave the ventricles of the heart, right? I hope that connection makes sense. So in order to keep stroke volume appropriate, to keep cardiac output appropriate, I've got to get that venous return, that blood coming back to the heart so that I can increase my preload, my end diastolic pressure or my filling pressure, increase my end diastolic volume or my filling volume, and then increase my stroke volume, how much is ejected, therefore increasing how much is going out to the systemic circulation on the other end. Okay, and all of this really is working to achieve maintaining mean arterial pressure. In other words, maintaining our blood pressure or our perfusion pressure, okay?